millions of people are going to swallow a pill today that is, well, chemically engineered to hijack their own white blood cells.
Right, and it just hitches a ride directly to the infected tissue.
Exactly. And then it lingers there inside their bodies for up to 10 days.
It really is wild. But the crazy part is a massive percentage of those people are going to take this incredibly complex molecule to fight a disease it has absolutely zero power to cure.
Zero power. None. And that tension is exactly what we were exploring today on this deep dive.
It's the ultimate paradox of modern pharmacology, honestly. We have engineered one of the most sophisticated, highly targeted antimicrobial agents in human history.
Wow.
And yet how we actually use it in the real world is often just completely irrational.
It is. So I want you, the listener, to mentally walk into your bathroom right now and open your medicine cabinet.
You probably got some interesting things in there.
Right. But look past the sunscreen, past the dental floss, and look at the prescription bottles. Chances are you've seen, or maybe you've personally taken, the medication on today's docket.
Zithromax.
Zithromax, universally known by its active ingredient as azithromycin.
It's everywhere.
It really is. And usually when we discuss medical treatments, there's this expectation of clean, binary precision, like break an arm, the x-ray shows the fracture, the doctor sets it, done.
Right. It's very straightforward.
But when you step into the world of internal medicine, of bacterial infections and global pharmacology, that clean x-ray machine just shatters.
Oh, absolutely. The landscape is wildly complex.
So our mission today is to move way past azithromycin's reputation as just that quick fix Z-Pack you grab at the pharmacy window.
Yeah, we really need to map out exactly what this powerful molecule is doing the millisecond it enters your bloodstream.
Which is a vital undertaking.
Yeah.
Because I feel like familiarity breeds this dangerous illusion of simplicity.
It does. Zithromax is so ubiquitous that we've just stopped questioning how it works.
Right. So to strip away that illusion, our roadmap for this exploration is drawn directly from the iMedix platform.
They're an independent medical information platform, right?
Yeah, they are. They've compiled this rigorously detailed clinical guide on azithromycin, synthesizing FDA data, pharmacokinetic profiles, and, massive troves of patient safety data.
It's a great resource.
I spent hours going through their databases last night, and what really struck me is that it's not just a static dictionary of side effects.
No, it's much more dynamic than that.
Right. It's designed to bridge the massive knowledge gap between the pharmacist's counter and your living room. So we're using their structural analysis to navigate this.
And whether you are currently nursing a respiratory infection, prepping for a doctor's visit, or you're just, fascinated by how everyday medicine manipulates human biology on a cellular level,
this exploration is going to change how you look at that little plastic bottle.
Absolutely. So to truly understand what azithromycin is doing inside your tissues right now, we have to look at its origin.
Right, because this molecule didn't just materialize out of thin air in some modern superlab.
No, the origin story from the historical pharmacology data is actually fascinating. It was synthesized in 1980 by a team of researchers at a Croatian pharmaceutical company called Pliva.
1980, in Zagreb, Croatia. I mean, that is a highly specific geopolitical environment.
It really was.
During the Cold War era, you don't typically associate Eastern European laboratories with the birth of a global blockbuster drug.
True, but it was an extraordinary scientific feat. The researchers at Pliva were trying to solve a very distinct chemical problem.
Okay, lay it on me.
So, azithromycin belongs to a family of drugs known as macrolide antibiotics. The grandfather of this class was erythromycin, which had been around since the 1950s.
Well, I've heard of erythromycin.
Most people have. It was effective, but it had a notoriously fragile chemical structure.
Yeah, looking at the molecular diagrams in the iMedix resources, erythromycin has what's called a 14-membered lactone ring.
Right.
And the problem with that specific ring structure is that it degrades rapidly when exposed to the harsh, highly acidic environment of the human stomach.
Precisely. Because it degraded in stomach acid, it produced these erratic byproducts.
So it's caused problems.
Major problems. Severe gastrointestinal cramping and nausea. The drug was essentially breaking down before it could even reach the bloodstream in optimal concentrations.
Wow. So what did the Croatian team do?
They performed a brilliant piece of molecular surgery. They took that 14-membered erythromycin ring and chemically forced a nitrogen atom into it.
Just one atom.
Just one, creating a 15-membered ring.
They created a subclass called an azolid. And just by adding that single nitrogen atom, they completely altered the drug's personality.
It became highly stable in stomach acid, which meant better absorption, but it also fundamentally changed how the drug interacts with human tissue.
Okay, but before we get into where the drug travels, we need to establish exactly how a macrolide fights an infection.
Good point.
Because I think the default visualization for most of us is that antibiotics are like microscopic explosives. You swallow the pill, it finds the bacteria, and boom, it blows the invading cell to pieces.
Yeah, that bacterial bomb concept describes a different class of drugs entirely.
Like penicillins.
Exactly, like penicillins, which destroy the bacterial cell wall, causing them to rupture and die. That is a bactericidal mechanism.
Bactericidal meaning it kills them.
Right. Azithromycin, however, operates on a bacteriostatic mechanism.
Bacteriostatic.
Yeah. If we look at the ribosomal binding data, macrolides work by inhibiting bacterial protein synthesis.
Okay, I was reading about this binding affinity. It specifically targets the 50S ribosomal subunit of the bacteria.
It does.
So if we drop the bomb analogy, what we were really looking at is industrial sabotage.
I like that analogy.
Because a bacterial cell is essentially a highly fortified microscopic factory. For that factory to survive, grow, and most importantly, replicate to spread the infection, it has to constantly manufacture proteins.
And the ribosome is the assembly line inside that factory. It reads genetic instructions and links amino acids together to build those essential proteins.
So azithromycin is a saboteur?
A highly specialized saboteur. It enters the bacterial cell, navigates to that 50S ribosomal subunit, and physically wedges itself into the machinery.
Wow.
It blocks the exit tunnel where the newly formed protein chain is supposed to emerge.
It jams the gears. The assembly line physically cannot move forward, so it doesn't actually kill the bacteria outright.
At standard clinical doses, no. It puts the bacterial population on a biological pause.
It just freezes them.
Exactly. They cannot synthesize the proteins required for cell division. The infection stops spreading.
But wait, this raises a critical point. If the drug isn't slaughtering the bacteria, how does the patient actually get well?
That is the million-dollar question. The drug is just holding the enemy forces at bay so your own white blood cells can catch up.
Oh, I see. They swarm the area and clear the infection.
Right. The azithromycin isn't the executioner, it's the tactical unit that paralyzes the target so your immune system can do the heavy lifting.
Which means if a patient has a severely compromised immune system, a bacteriostatic drug like azithromycin might not be sufficient on its own.
That is a crucial clinical distinction. And this brings us back to that single nitrogen atom the Croatian scientists added.
The structural upgrade.
Yeah, that upgrade didn't just make the drug acid stable, it dramatically increased its lipophilicity.
Lipophilicity, meaning it loves fat and repels water.
Exactly. Because the molecule is highly lipophilic, it does not like to stay in the watery environment of human blood plasma.
Wants out of the blood.
Immediately. As soon as azithromycin enters the bloodstream, it actively seeks out the lipid-rich membranes of human tissue cells and dives inside them.
Which perfectly explains why blood serum concentrations of azithromycin are incredibly low, but tissue concentrations are massive.
It does.
And this is the part of the iMedix pharmacokinetic data that completely blew my mind. It doesn't just passively absorb into static muscle or lung tissue. It actively accumulates inside phagocytes.
Are macrophages and polymorphonuclear leukocytes?
Or white blood cells.
It is an unintentional Trojan horse mechanism. The azithromycin molecule concentrates inside the very immune cells that your body naturally deploys to fight an infection.
That is brilliant. So when you have bacterial pneumonia, your immune system flags the lung tissue and sends thousands of macrophages to the site.
And those macrophages are completely loaded with azithromycin.
So the drug is literally hitching a ride on the body's own first responders.
Yes. The white blood cell arrives at the infection site, encounters the bacteria, begins the process of phagocytosis.
Engulfing the bacteria.
Right. And in doing so, it releases a massive concentrated payload of azithromycin directly onto the pathogen.
It is targeted drug delivery utilizing the host's own immune infrastructure.
It really is.
Really is.
And this mechanism is the biological foundation for the drug's most famous clinical application.
The Z-Pack.
The Z-Pack.
The 5-day regimen that completely upended how we treat respiratory infections. I mean, anyone who has dealt with a stubborn sinus infection knows the traditional drill with older drugs.
You are chained to a pill bottle for 10 to 14 days.
Right, taking massive capsules 2 or 3 times a day, you miss a dose, you panic. But the Z-Pack condenses the entire treatment into 6 pills.
2 250-milligram tablets on day 1, and then 1 pill daily for days 2 through 5.
But wait, looking at the math, there is a glaring contradiction here. If I stop taking the medication on Friday, How am I protected through the following Wednesday?
The answer lies in a pharmacokinetic metric called the terminal elimination half-life.
Okay, break that down for us.
A half-life is the exact amount of time it takes for the active concentration of a drug in your body to reduce by 50%.
Right.
Many common antibiotics, like amoxicillin, have a half-life of roughly an hour. You have to constantly supply the body with new pills to keep the blood levels high enough to suppress the bacteria.
But because azithromycin abandons the blood and hides deep inside the tissue cells and white blood cells, its half-life is staggering. The clinical data shows a half-life of up to 68 hours.
Almost 3 full days just for the drug concentration to drop by half. So when you take the initial 500 milligram loading dose on day 1, you are aggressively saturating your tissue cells.
And the subsequent doses.
The 250 milligram doses on days 2 through 5 simply top off the reservoir. By the time you swallow that final pill, your tissues are so heavily loaded with the drug that it takes another 5 to 7 days for it to slowly leach out and be eliminated.
So you are getting 10 days of antimicrobial coverage from 5 days of dosing.
Exactly.
It is front-loading the system so the drug can work overtime while you have already put the pill bottle away.
It's remarkably efficient.
And for some specific infections, the iMedix database outlines regimens that are even more aggressive than the 5-day pack.
Oh, definitely. The treatment protocols for uncomplicated sexually transmitted infections, specifically chlamydia trachomatis, utilize this exact pharmacokinetic profile.
So,
The standard treatment is a single massive 1-gram dose, 2 500 milligram tablets taken simultaneously, and the treatment is entirely complete.
just one dose and you're done.
Yep. For gonorrhea, the protocol often involves that same 1-gram oral dose combined with an intramuscular injection of a different antibiotic, ceftriaxone.
That dual therapy for gonorrhea is a direct response to the bacteria mutating and developing resistance, isn't it?
Unfortunately, yes. It's an evolutionary arms race we are currently losing.
But focusing on that single 1-gram dose for chlamydia, why does this condensed duration matter so much? From a purely pharmacological standpoint, wouldn't a steady 10-day drip of medication be a safer, less aggressive way to treat the body than hitting it with a 1-gram sledgehammer?
Well, it would be if humans were perfectly rational machines.
Fair point.
But we are not. The fundamental variable that makes the Z-Pak and the single-dose therapy so revolutionary is patient adherence.
People forgetting to take their pills.
The medical reality is that people are notoriously terrible at finishing 14-day courses of medication.
I'm guilty of this. You get to day 6, the fever breaks, the coughing stops, you feel subjectively cured, and you just abandon the remaining pills in the cabinet.
Which is catastrophic from a microbiological perspective.
Why? What happens?
When you stop an antibiotic early, you have not sterilized the environment. You have only suppressed the weakest, most susceptible bacteria.
Oh no.
The most resilient organisms, the ones with slight genetic variations that allow them to tolerate the drug a bit longer, they survive the initial assault.
And then they multiply.
Exactly. When you stop the medication, these hardened survivors multiply. You have just artificially selected for a stronger strain of bacteria, and now they have been exposed to the drug. They learn its chemical signature.
So the 5-day Z-Pak bypasses human error.
It does. Compliance skyrockets when the finish line is only 5 days away, or in the case of STIs, an immediate single dose. It physically guarantees that the patient receives the full therapeutic exposure required to eradicate the pathogen before it can mutate.
That makes total sense.
However, that sheer convenience is a double-edged sword.
How so?
Because the Z-Pak is so user-friendly and so heavily marketed, it has become deeply entrenched in the public consciousness. It is viewed as a magic wand for feeling sick.
Right.
And that cultural ubiquity has led to widespread, rampant, and highly dangerous misuse.
Which brings us to the most critical public health message embedded in the iMedix platform. I'm going to state a biological absolute here for you listening. Zithromax is fundamentally chemically incapable of treating a viral illness.
Say it louder for the people in the back.
It will not cure the common cold. It will not touch influenza. It is completely useless against COVID-19.
We have to return to the mechanism of action. Azithromycin binds to the 50S ribosomal subunit of a bacterial cell.
Right, the factory assembly line.
Viruses do not have ribosomes. They do not have their own cellular machinery. A virus is essentially just a packet of genetic material wrapped in a protein coat.
So how do they survive?
It survives by invading human cells and hijacking our human ribosomes to replicate itself.
And because azithromycin is designed to specifically ignore human ADS ribosomes, which is why the drug doesn't just shut down our own cellular factories, It has absolutely no target when a virus is replicating inside us.
None.
Throwing azithromycin at a viral cold is like trying to shut down a computer virus by physically pouring motor oil on the keyboard. You are using a mechanical solution for a software problem.
That's a great way to put it. Yet, primary care physicians face intense daily pressure from patients demanding a Z-Pak the moment they develop a scratchy throat.
I can imagine.
There is a deeply illustrative anecdote in the user review section of the iMedix page that perfectly captures this dynamic.
Oh yeah, the favor review.
Yes, a user named Favor shared that her sister, who is a doctor, prescribed Zithromax for a severe sore throat. Favor wrote that after 2 days of taking the pills, she felt a significant reduction in pain. The iMedix editorial team replied to this comment, acknowledging her recovery but strictly reminding users to complete the full course even when symptoms improve.
It's a fascinating microcosm of real-world medicine.
Yeah.
In Favor's specific case, because a physician diagnosed it and prescribed it, it is highly probable she had a confirmed bacterial infection, such as streptococcal pharyngitis, strep throat.
Exactly. In that exact biological context, azithromycin jamming the bacterial ribosomes worked perfectly, and symptom relief within 48 hours is exactly what you would expect.
The insidious danger lies in how the general public interprets that sequence of events.
Yes.
Someone sitting at home with a rhinovirus, the common cold reads that review and thinks, a Z-Pak cures a sore throat.
And they bully their doctor into writing the prescription, or they find an old bottle in their cabinet, they take the 5-day course.
Now, we know the typical viral upper respiratory infection naturally resolves via the patient's own immune system in about 5 to 7 days anyway.
Right. I see exactly where this is going, the psychological trap.
It is the post hoc ergo propter hoc fallacy. After this, therefore because of this.
The classic logical error.
The patient finishes their inappropriate 5-day Z-Pak on Friday. On Saturday, their immune system finally clears the virus naturally. The patient wakes up feeling better and immediately, falsely, credits the azithromycin for the cure.
It's a massive cognitive bias that heavily reinforces the demand for the drug. The patient goes back to the doctor next year, demands the Z-Pak again, and points to their previous success as proof that it works.
But taking a powerful macrolide antibiotic for a viral infection isn't just a harmless placebo effect. You are initiating a cascade of collateral damage inside your body for absolutely zero therapeutic benefit.
Azithromycin is a broad-spectrum antibiotic. When we say broad-spectrum, we mean it does not discriminate between the pathogenic bacteria causing your pneumonia and the billions of commensal beneficial bacteria that naturally live inside your body.
I used to think of this collateral damage like clear-cutting an ancient forest to get rid of some weeds, but reading through the microbiome data, a better analogy is disrupting a highly complex microscopic coral reef.
I like the coral reef analogy better.
Because your gastrointestinal tract is this incredibly diverse, delicate ecosystem. You have massive populations of bacteroidetes and firmicutes, these distinct bacterial phyla that are actively digesting your food, synthesizing vitamins, and regulating your immune responses.
And when you drop azithromycin into that ecosystem, it acts like a massive chemical bleaching event.
A bleaching event, that's a visceral image.
The immediate, acute result of that ecological disruption is evident in the iMedix side effect profile. The most commonly reported adverse events are gastrointestinal, severe diarrhea, nausea, abdominal cramping, and vomiting.
Because the drug wipes out the flora that normally regulates bowel motility and water absorption.
Exactly, throwing the entire digestive tract into chaos.
For most people, that means a few days of intense discomfort. But there's a secondary consequence to bleaching that coral reef, and it involves a specific pathogen called Clostridioides difficile, or C. diff.
This is a critical safety concern highlighted across every major pharmacological database.
What is C. diff exactly?
C. diff is an opportunistic, spore-forming bacterium. In a healthy human gut, C. diff might actually be present in very small, harmless numbers.
Okay.
It is kept entirely in check by the billions of healthy bacteria competing for nutrients in space. But when azithromycin sweeps through and eradicates that healthy population, it creates an ecological vacuum.
The competition is eliminated.
Precisely. And because C. diff can form resilient spores, it often survives the initial antibiotic onslaught. Once the competing flora is gone, C. diff rapidly shifts out of its spore phase and proliferates wildly.
And that's when it causes problems.
Major problems. As it multiplies, it releases toxin A and toxin B, which directly attack the epithelial lining of the colon.
This leads to C. diff-associated diarrhea, which can progress to pseudomembranous colitis.
A life-threatening inflammation of the colon.
characterized by severe, watery, bloody diarrhea, high fever, and excruciating abdominal pain. And the truly terrifying aspect of this pathogenesis is the timeline. The iMedix clinical warnings specifically note that C. diff colitis can emerge weeks or even up to 2 months after the patient has taken their final dose of azithromycin.
Because the ecological damage to the gut microbiome can persist long after the drug has been eliminated from the tissue.
So if a listener has taken antibiotics and develops severe, unrelenting diarrhea weeks later, they must not assume it's just a random stomach bug.
Definitely not. It requires immediate clinical intervention, often with highly specific, targeted antibiotics designed exclusively to kill C. diff.
To mitigate the basic gastrointestinal irritation, the iMedix guide does offer some highly practical pharmacology tips. If you're an adult taking the standard tablet form, you can take it with food.
That helps a lot.
Having a physical buffer of food in the stomach does not significantly impair the drug's overall absorption, but it drastically reduces the localized chemical irritation that causes nausea.
However, there is a crucial caveat regarding the pediatric formulation.
Oh, the liquid suspension for kids.
Yes. Azithromycin for children is frequently prescribed as a liquid oral suspension. The physical properties of the suspension dictate that the active drug particles settle heavily at the bottom of the bottle.
So you have to shake it.
The instructions mandate aggressive, vigorous shaking before every single dose to ensure the active molecule is evenly distributed throughout the viscous liquid.
And the administration of that liquid brings up a massive point of patient error. The guide explicitly warns against using household spoons.
Please do not use a household spoon.
I think a lot of parents default to a kitchen teaspoon at 2 a.m. when their kid is crying, assuming a spoon is a standardized unit of measurement.
It absolutely is not. The volume of a household teaspoon can range anywhere from 3 milliliters to over 7 milliliters, depending entirely on the manufacturer's design and the meniscus of the liquid poured into it. Pediatric azithromycin is meticulously dosed based on the child's exact body weight in kilograms. If the prescribed dose is exactly 5 milliliters, using a random kitchen spoon can easily result in subtherapeutic underdosing,
which fails to clear the infection and actively promotes bacterial resistance.
or dangerous overdosing, which dramatically spikes the risk of systemic side effects. You must use the calibrated oral syringe provided by the pharmacy.
Because when we talk about overdosing or systemic side effects, we are moving past stomach aches into some highly bizarre, deeply concerning physiological reactions. The iMedix data highlights a specific phenomenon called ototoxicity.
Reversible hearing loss and tinnitus.
Ototoxicity is a rare but profound adverse event, typically associated with higher than normal doses or prolonged intravenous administration. While the precise molecular mechanism is still being mapped, the leading pharmacological theory focuses on the accumulation of azithromycin in the inner ear.
The inner ear is a closed, fluid-filled system, the cochlea.
Yes. The cochlea relies on an incredibly delicate balance of potassium ions in the endolymph fluid. This ionic gradient is what allows the stereocilia, the microscopic hair cells, to translate physical sound waves into electrical signals for the brain.
Right, and as azithromycin appears to accumulate in this fluid and disrupt those ion channels, temporarily paralyzing the hair cell's ability to transduce sound.
So a patient taking a high dose for a severe infection might suddenly experience a persistent, high-pitched ringing tinnitus or a noticeable muffling of their hearing.
Which is terrifying.
The literature indicates this is generally reversible once the drug is discontinued and the tissue concentration drops. But I cannot imagine the psychological distress of taking a pill for pneumonia and waking up partially deaf.
It underscores the systemic power of the molecule. And that systemic power is further demonstrated by an absolute contraindication for patients with myasthenia gravis.
That's an autoimmune neurological disorder, right?
Yes, characterized by varying degrees of weakness in the skeletal muscles.
The immune system attacks the receptors at the neuromuscular junction, where the nerves communicate with the muscles.
Exactly. The nerves release acetylcholine to tell the muscles to contract, but the receptors are blocked or destroyed by antibodies. Azithromycin has been clinically observed to act as a presynaptic blocker.
So it makes it even harder for the nerves to communicate.
It can further inhibit the release of acetylcholine from the nerve terminals. In a healthy person, this microscopic reduction is entirely unnoticeable. But in a patient with myasthenia gravis, whose neuromuscular junctions are already critically compromised, this added blockade can induce a severe exacerbation of muscle weakness.
And if that weakness extends to the diaphragm and the intercostal muscles, the muscles required to physically expand the lungs, the patient can rapidly enter respiratory failure.
It is a stark, vital reminder that a drug considered perfectly safe for 99% of the global population can be a lethal catalyst for someone with a specific underlying physiological vulnerability.
Which serves as the perfect transition into the highest tier of medical alerts found in the iMedix database. We are moving from rare sensory disruptions to the FDA black box warning.
The most serious warning they have.
When the Food and Drug Administration places a warning inside a literal, bold black box at the very top of a prescribing label, it is their most severe communication tool. It is a mandate for prescribers to weigh the immediate risk of death.
And for azithromycin, that black box warning is entirely focused on the heart, specifically a cardiac anomaly known as QT interval prolongation.
When I first read QT interval, my brain immediately went to automotive repair. It sounds like a spark plug misfire.
Actually, looking at the electrophysiology of the heart, the engine analogy is incredibly accurate.
Okay, break that down for me.
The human heart does not beat via mechanical gears. It is driven by an exquisitely timed electrical current. This current is generated by the rapid, highly coordinated flow of electrically charged ions, sodium, calcium, and potassium moving in and out of the heart muscle cells.
On an electrocardiogram, an EKG, this electrical cycle is mapped in waves.
The Q, R, S, and T waves.
Exactly. The QT interval is the physical measurement of time it takes for the heart's lower chambers, the ventricles, to electrically fire and then completely reset themselves, preparing for the next beat.
It is the repolarization phase. Azithromycin has a known affinity for blocking a very specific potassium channel in the heart muscle cells, known as the HERG channel.
By physically blocking the HERG channel, the drug traps potassium ions inside the cell for just a fraction of a second longer than normal. It physically delays the electrical reset.
It stretches out the QT interval on the EKG monitor.
And if that interval stretches too far, the heart's electrical timing loses its synchronization.
A new heartbeat tries to initiate before the previous repolarization is fully complete. This collision of electrical signals can trigger a chaotic, excessively fast, and highly dangerous polymorphic ventricular tachycardia.
The specific clinical term for this arrhythmia is torsade de pointe, which translates from French to twisting of the points.
It is named for how the erratic, wild electrical rhythm physically looks on an EKG readout. The waveform appears to twist around the baseline. Torsades de pointe is a critical medical emergency because it drastically reduces the heart's ability to pump blood effectively, causing the patient to lose consciousness.
More importantly, it can rapidly degenerate into ventricular fibrillation.
Ventricular fibrillation is cardiac arrest. The heart isn't pumping at all, it's just quivering. Without immediate CPR and electrical defibrillation, it is fatal.
So we have to pause here and address the massive glaring question. If the most commonly prescribed 5-day antibiotic in the world has the molecular potential to trigger a fatal cardiac arrest, why isn't the FDA pulling it off the market? Why are doctors handing this out like candy?
Because in pharmacology, risk is rarely absolute, it is highly contextual. The baseline risk of a healthy 30-year-old with a normal heart spontaneously developing torsades de pointe from a standard Z-pack is infinitesimally small.
Ah, I see.
The black box warning is not a blanket ban. It is a highly targeted alert for vulnerable populations. The risk of this electrical collision is exponentially magnified if the patient already has pre-existing structural heart disease or a history of arrhythmias.
The iMedix clinical guidelines specifically flag patients with bradycardia and abnormally slow resting heart rate because a slower baseline rhythm naturally elongates the QT interval, pushing them closer to the danger zone before the drug is even introduced.
And critically, the warning highlights the severe danger of hypokalemia and hypomagnesemia.
Low potassium and low magnesium in the blood.
Yes, potassium and magnesium are the literal currency of the heart's electrical system. If a patient is severely deficient in these electrolytes, perhaps because they take heavy diuretics for high blood pressure, or they have been suffering from severe vomiting and diarrhea, their heart cells are already struggling to repolarize effectively.
Introducing azithromycin, a known potassium channel blocker, into an environment already starved of potassium is the pharmacological equivalent of throwing a match into a powder keg.
It's a compounding, stacked risk. But it is worth noting that large-scale epidemiological studies comparing azithromycin to older alternative antibiotics like amoxicillin have demonstrated a small but statistically significant increase in cardiovascular mortality associated with the azithromycin group.
It's not a zero-risk scenario.
No, which is why clinical guidelines are actively shifting. If an older patient with a questionable cardiac history presents with a sinus infection, the physician must critically evaluate if a macrolide is truly necessary or if a safer alternative will suffice.
The heart is the primary focus of the severe warnings, but the liver is also heavily implicated. The database details cases of severe hepatotoxicity liver injury.
Which makes sense considering the massive tissue accumulation we discussed earlier. The drug eventually has to be metabolized and cleared from the body, and the liver bears the brunt of that chemical processing.
The clinical presentation of this toxicity is often cholestatic jaundice. The azithromycin can induce an inflammatory response in the liver that physically impairs the flow of bile.
When bile cannot exit the liver into the digestive tract, bilirubin, a yellow pigment created by the normal breakdown of red blood cells, backs up into the systemic circulation.
The patient's skin and the sclera, the whites of their eyes, literally turn yellow. The bilirubin is also excreted through the kidneys, turning the urine a dark, concentrated amber or brown color.
If a patient on a Z-Pak notices their eyes turning yellow or experiences sudden, severe pain in the upper right quadrant of their abdomen, that is not a standard side effect to sleep off. That is a signal to stop the medication immediately and seek emergency care.
Similarly urgent are the dermatological warnings. Azithromycin is linked to severe, rare cutaneous adverse reactions, most notably Stevens-Johnson syndrome.
SJS is a horrific immune hypersensitivity reaction. The immune system fundamentally misidentifies the drug molecule as a massive threat and launches a cytotoxic T-cell attack against the patient's own epidermis, the top layer of the skin.
The skin erupts in painful blisters, dies, and physically peels off in large sheets, mimicking the presentation of a severe, full-body thermal burn.
It compromises the body's ability to regulate temperature and drastically increases the risk of massive secondary bacterial infections.
The overarching takeaway from this safety data is vigilance. Commonly prescribed does not equate to biologically inert. If you experience a racing, irregular heartbeat, sudden yellowing of the skin, or a rapidly spreading rash, you must advocate for yourself immediately.
Which perfectly sets up the next layer of complexity. The risk to your heart and liver isn't just dictated by your genetic baseline or your electrolyte levels. It is heavily dictated by the other chemical compounds currently circulating in your bloodstream.
Because azithromycin does not exist in a vacuum. This brings us to the staggering list of drug interactions documented in the iMedix database. It is a massive chemical traffic jam.
Drug interactions represent one of the most intellectually demanding aspects of prescribing medicine. To understand how azithromycin interferes with other drugs, we have to zoom in on the liver's metabolic infrastructure.
Right.
The human liver contains a massive family of enzymes known as the cytochrome P450 system.
Think of this system as a sprawling, highly specialized chemical disassembly plant. Different assembly lines within the plant are responsible for breaking down different types of molecules so the body can safely excrete them in urine or bile.
One of the busiest, most critical assembly lines in the hepatic plant is an enzyme called CYP3A4. This single enzyme is responsible for metabolizing roughly half of all prescription drugs currently on the market.
And this is where the conflict occurs. Azithromycin acts as a competitive inhibitor of CYP3A4.
Exactly.
When the azithromycin molecule enters the liver, it physically binds to the active site of the CYP3A4 enzyme, blocking it.
It shuts down the assembly line. And the most dangerous downstream effect of this shutdown involves a class of drugs taken daily by tens of millions of adults globally: statins.
Medications like simvastatin and lovastatin prescribed to lower cholesterol. Let's visualize this traffic jam. The statins are cars driving on a major highway, needing to take the CYP3A4 exit ramp into the liver to be broken down and cleared from the blood.
But azithromycin is a jackknifed semi-truck, completely blocking that exit ramp.
Because the statins cannot exit the bloodstream to be metabolized, they simply continue to circulate. The patient takes their statin pill on Tuesday and Wednesday and Thursday, and because the exit is blocked, the concentration of statins in the blood piles up higher and higher, reaching severely toxic levels.
That is a highly accurate visualization of competitive enzyme inhibition. And when statin concentrations reach toxic thresholds, they become directly poisonous to skeletal muscle fibers.
The clinical term is myopathy. Patients experience severe, unexplainable muscle aching and weakness.
But it can escalate far beyond aching. If the traffic jam isn't cleared, myopathy can rapidly degenerate into rhabdomyolysis. This is a catastrophic cascading breakdown of skeletal muscle tissue. The muscle cells literally rupture and die, spilling their intracellular contents directly into the systemic circulation.
The most dangerous component of that cellular spill is a protein called myoglobin. Myoglobin is essential inside the muscle for storing oxygen, but it is highly toxic when floating freely in the blood.
Because the kidneys have to filter the blood. The renal filtration system is composed of microscopic tubules. The myoglobin proteins are large and physically irregular. When they reach the kidneys, they literally clog the tubules, causing direct structural damage and inducing acute renal failure.
The kidneys shut down. All because a patient took a 5-day antibiotic for a cough without pausing their daily cholesterol medication.
This specific interaction is why modern pharmacological software will immediately flag a co-prescription of simvastatin and azithromycin. A physician will typically instruct the patient to entirely hold their statin therapy for the duration of the antibiotic course and for several days after to allow the CYP3A4 enzyme to clear.
Let's navigate through a few other critical interactions mapped out in the database. Warfarin, heavily prescribed as a blood thinner or an anticoagulant for patients at risk of strokes or blood clots.
Warfarin has a notoriously narrow therapeutic index. It requires exact dosing to keep the blood thin enough to prevent clots, but thick enough to prevent spontaneous hemorrhage.
And azithromycin messes with that.
Yes. Azithromycin alters the gut flora that synthesize vitamin K, a crucial component in the blood clotting cascade, and can also mildly inhibit warfarin metabolism. The result is a potentiation of the anticoagulant effect. The blood becomes dangerously thin.
The patient's INR, their international normalized ratio, which measures the speed of coagulation spikes. A minor bump against a table could cause massive deep tissue bruising, or worse, internal bleeding. Anyone on warfarin who is prescribed a macrolide must have their INR monitored obsessively by a coagulation clinic.
What about something over-the-counter like antacids? If the azithromycin causes gastric distress, the natural instinct is to grab a bottle of liquid antacid.
This is a physical interaction rather than a metabolic one. Liquid antacids heavily rely on aluminum and magnesium hydroxide to neutralize stomach acid. If you swallow an aluminum-based antacid at the exact same time as your azithromycin tablet, the metal ions physically bind the macrolide ring of the antibiotic in the stomach.
It creates a heavy, insoluble chemical complex chelation.
Exactly. The human intestine cannot absorb this large, chelated complex. The azithromycin molecule is physically trapped by the antacid, passes straight through the digestive tract, and is excreted in the feces.
You have effectively flushed your antibiotic down the drain, leaving the infection completely untreated. The strict pharmacological rule is chronological separation. You must take the azithromycin at least 1 hour before or 2 full hours after ingesting any aluminum or magnesium antacids.
There are also warnings for specialized medications like digoxin, a cardiac glycoside used for heart failure, and nilfinavir, an antiretroviral drug used in HIV treatment.
Azithromycin interferes with a specific transport protein in the intestines called P-glycoprotein, which normally pumps a portion of drugs like digoxin back into the gut to prevent overabsorption. By inhibiting this pump, azithromycin causes a massive surge in digoxin blood levels, which can trigger severe nausea, visual disturbances, and fatal cardiac arrhythmias.
It's another example where co-administration requires intense laboratory monitoring. And finally, we have to address the most universally asked question in the history of pharmacy counters. Can I drink alcohol while taking this?
From a strictly chemical standpoint, ethanol does not competitively bind with azithromycin, nor does it physically neutralize the drug's bacteriostatic properties. A glass of wine will not stop the antibiotic from jamming the bacterial ribosomes.
However,
It is strongly medically discouraged due to compounded physiological stress. Alcohol is a potent gastrointestinal irritant. It inflects the stomach lining and increases gastric motility. Azithromycin, as we established, already causes severe GI distress and diarrhea.
mixing them guarantees a profound exacerbation of nausea and dehydration. Furthermore, your liver is currently under significant metabolic load processing the tissue accumulations of the antibiotic. Forcing the liver to simultaneously metabolize ethanol is placing an unnecessary toxic burden on an organ vital to your recovery.
It's an issue of physiological bandwidth. You want your system focused on fighting the pathogen, not processing a cocktail. Given this incredibly dense maze of half-lives, enzyme traffic jams, and cardiac risks, it is a testament to the drug's overall efficacy that it remains a frontline staple across so many different demographics.
Which brings us to how specific populations access and utilize this drug and the massive looming threat of the global gray market.
In the context of special populations, azithromycin is a cornerstone of pediatric medicine. The ease of the once-daily liquid suspension, combined with the short 5-day duration, ensures high compliance rates in children who otherwise fight taking medication. It is also generally categorized as safe during pregnancy when a bacterial infection poses a greater threat to fetal development than the drug itself.
But the iMedix database points out an absolute game changer for a very specific, highly vulnerable group, patients with a confirmed penicillin allergy.
Roughly 10% of the population carries a medical chart labeled with a penicillin allergy. For these individuals, standard beta-lactam antibiotics like amoxicillin or cephalexin are strictly off limits due to the risk of anaphylactic shock.
Because penicillin relies on a specific molecular structure called a beta-lactam ring to destroy the bacterial cell wall, and the patient's immune system has developed IgE antibodies, specifically targeting that ring. But azithromycin, as we discussed back in 1980 with the Croatian scientists, is built on a massive 15-membered azolid ring.
The chemical structures are so wildly different that there is absolute zero cross-reactivity. The immune system of a penicillin-allergic patient does not recognize the macrolide structure as a threat. Azithromycin provides a highly potent, life-saving alternative for severe respiratory or skin infections when the frontline beta-lactams cannot be deployed.
But the accessibility of this drug has a deeply concerning dark side. We discussed earlier that a massive 1-gram single dose is the gold standard for treating uncomplicated chlamydia trachomatis. Because sexually transmitted infections carry such a heavy, unfortunate social stigma, many patients feel intense psychological barriers to seeking care.
They are too embarrassed to sit in a clinic waiting room or have that conversation with their primary care doctor.
And in the digital age, that embarrassment drives patients to seek out discreet, unregulated online pharmacies. They attempt to purchase azithromycin over the internet without a valid prescription or medical oversight.
This is where the iMedix platform serves as a massive warning siren. Their medication database doesn't just list FDA-approved therapeutics, it categorizes the vast, chaotic ecosystem of global pharmacology. Right alongside the verified data for Zithromax, they list international analogs.
They explicitly track non-FDA-approved gray market generics drugs manufactured in overseas facilities with zero regulatory oversight. The database references names like Comagra, Cilagra, and Senforce.
To be precise, looking at the pharmacological mapping, those specific brands, Comagra and Cilagra, are actually unregulated, generic analogs of sildenafil, an erectile dysfunction medication. But the structural warning iMedix is highlighting applies uniformly across all classes of drugs sold in these digital shadows, especially antibiotics.
The internet is flooded with unverified pharmaceutical compounds masquerading as legitimate therapies. When a panicked patient logs onto a sketchy website to secretly buy azithromycin to cure an STI, they are stepping into a regulatory void. They have absolutely no guarantee of the chemical composition of the pill arriving in the mail.
The immediate fear is counterfeit medication pills pressed from chalk, talcum powder, or heavy metals. If the pill is biochemically inert, the patient's chlamydia infection simply ravages the reproductive system unchecked, potentially leading to pelvic inflammatory disease and permanent infertility.
But from a global public health perspective, an inert chalk pill is actually the lesser of two evils. The catastrophic apocalyptic scenario is purchasing a substandard underdosed product.
That is the nightmare scenario for microbiologists. Imagine the online pill contains actual azithromycin, but due to terrible manufacturing standards, it only contains 150 milligrams instead of the required 1,000 milligram curative dose.
You take the sublethal dose. The concentration in your tissue isn't high enough to freeze the ribosomes of the entire bacterial population.
No.
You expose the bacteria to just enough of the macrolide poison to agitate them, to apply evolutionary pressure, but not enough to eradicate them.
You have effectively created a biological training camp. The surviving bacteria recognize the chemical threat. Through spontaneous mutation or through a process called horizontal gene transfer, where bacteria literally swap plasmids of DNA with each other, they develop defense mechanisms.
They might mutate the shape of their 50S ribosome so the azithromycin can no longer bind to it. Or they might develop efflux pumps, which are microscopic cellular vacuums that physically pump the antibiotic back out of the bacterial cell before it can do any damage.
You take an underdosed pill to avoid an awkward doctor's visit, and in doing so, your own body becomes the incubator for a mutated, heavily armed, completely drug-resistant superbug. A strain of chlamydia or gonorrhea that no longer responds to macrolides at all, and then you pass that superbug on to the next person.
It is the ultimate failure of pharmacological stewardship. The brilliant chemical engineering of the 15-membered ring is entirely neutralized by the behavioral failure of the human accessing it outside the bounds of medical science.
We've covered a staggering amount of ground today. Let's trace the arc of this molecule one last time. We started in 1980 in a Croatian lab, where a simple nitrogen atom insertion stabilized a fragile molecule, giving birth to a highly lipophilic compound.
We explored how that compound uses our own white blood cells as Trojan horses, diving into our tissues to establish a 68-hour half-life that revolutionized compliance with the 5-day Z-Pack.
We examined the profound dangers of deploying this ribosomal saboteur against viral colds that lack ribosomes entirely. We mapped the collateral damage to the gut microbiome and the threat of C. diff, the rare but severe risks of ototoxicity, and the critical FDA warnings regarding the HERG channel, QT prolongation, and fatal arrhythmias.
We navigated the liver's CYP3A4 metabolic traffic jams, understanding exactly why mixing this drug with statins can literally destroy your kidneys with muscle proteins. And finally, we confronted the existential threat of unregulated digital access, where underdosing is actively training the next generation of untreatable pathogens.
The clinical data mapped out by iMedix makes one thing abundantly clear. Health literacy is the most potent protective medicine you can acquire. The pharmacist dispensed the molecule, but the patient must wield it responsibly.
You are the final, definitive line of defense in your own healthcare. Advocate for yourself. Ask your physician if the antibiotic is truly necessary, or if it's just a placating gesture for a viral cough. Cross-reference your other medications. Above all, respect the pharmacology, take the exact dose, finish the entire course, and never hoard leftover pills to self-diagnose in the future.
And, it's about thinking long-term, too.
Right. I want to leave you with a final thought to mull over the next time you look at that plastic bottle in your medicine cabinet. Azithromycin was a genuine miracle of 20th century chemical engineering, but its global dominance relied heavily on the sheer behavioral convenience of a 5-day regimen.
It made saving our own lives fast and easy.
But as we continue to casually abuse it, demanding it for viral sniffles, allowing the agricultural industry to overuse it, and buying unverified sublethal doses from the dark corners of the internet, we are actively forcing microscopic bacteria to evolve much faster than our macro-level pharmacology can keep up. If we break the magic of the 5-day Z-Pack through our own reckless misuse today, are you prepared for the 30-day intravenous-only hospital isolations of tomorrow?
A sobering but absolutely necessary question for the future of medicine.
Until next time, stay curious, stay informed, and keep diving deep.